shall I?
Please.
Yeah, ma'am. So first with Planet's video, I will start, then I will hand over to you, ma'am. Is it okay?
Yeah.
Okay. Very good evening and a warm welcome to all the doctors present here. I am Debulina from Planet. We are very much proud to be a part of this webinar as a digital partner. So now without further delay, I would like to share a short glimpse of Planet with all of you. Thank you so much all for your patience. We'll invite all the doctors to visit our website, which is www.planet.com. So now, without further delay, we'll proceed for our session. And for that, I would like to invite Dr. Lakshmi, with Ops and Gynae at Government Medical College. Ma'am is also president of Calicut Menopause Society from 2022 to 2023. Over to you, ma'am, for your presentations.
You can stop sharing that. Okay. A very good evening to one and all. At the outset, I would like to extend a hearty welcome to our National President, Dr. Shobna Mohandas, who has masterminded this webinar series, which we are conducting every Tuesday. And today, Calicut Menopause Society is proud to be the host for this webinar on fibroids. Next, I would like to extend a hearty welcome to our distinguished chief guest, Dr. Suvarna Khadilkar, our former National President. Let me also welcome our guests of honor, Dr. Jignesha, our former National President, and Dr. Anju Soni, our present Secretary General of IMS. A very warm welcome to our immediate past National President, Dr. Ambuja Madam. Welcome, Madam. Let me extend a hearty welcome to all our distinguished chairpersons of the day. Dr. Lalitambika, I think Madam has not yet joined, Dr. Beena Guhan, Dr. Chandramati, and Dr. Jeena Baburaj. A very special welcome to my beloved teacher, Professor N.S.V. Devi, who will be the moderator for today's panel. Welcome, Madam. Hearty welcome to my co-panelists, Dr. Mumtaz, who is also the Secretary of Calicut Menopause Society, Dr. Santosh Kuriakose, Dr. Hira Prabhu, Dr. Fatima Tasneem. Not to forget our very eminent guest speaker, the interventional radiologist, Dr. Taufiq from Al-Shifa, KIMS Al-Shifa Perindalmanna. A very hearty welcome to all of you. Let me extend a very warm welcome to each and every one of our viewers who have registered for today's program. Happy learning to all. Debolina, you can take over. Okay, I think Dr. Suvarna is in a hurry to leave. Madam, I welcome you and as a chief guest of today's function, and kindly say a few words on this occasion. Madam, you're muted.
जाने लगी 4 बजे बारिश आ रही थी ना तब.
Suvarna, Madam, you're muted.
Ma'am, please unmute. Suvarna, ma'am, please unmute.
Yeah, actually, I was unmuted. The admin muted me. I didn't realize unmuted. Okay, anyway, good evening to all. And it's a pleasure to be here at this very important seminar that Calicut Menopause Society has organized. I think this year, Calicut Menopause Society has special place at national level because this year's national president, very, very dynamic and hardworking Dr. Shobna Mohandas is a founder of Calicut Menopause Society, and I'm sure Calicut Menopause Society has a special place this year. So I think Shobna has done wonderful work in Calicut Menopause Society as well as on national front. And I'm really very happy. She is my dear friend, and I've seen her through how hard she has worked, and she has done such great work. And I firstly like the theme she has chosen for the webinar, that is the fibroid management. And I just was going through the program, and most of the programs have been on, rather conservative treatment of fibroid. I think she herself is speaking on medical management of fibroid, uterus, interventional uterine artery embolization. And I see Dr. Lakshmi, who is the president of Calicut Society, and under her leadership, the entire Calicut Menopause Society, one of them. I always say that fibroid uterus, when we were residents, there was only one answer for a senior, a woman of a little elderly age, and that was hysterectomy. And a young woman, we used to do myomectomy. There was hardly any, knowledge about medical management of fibroid then. But today we have such vast, believe me, as a chairperson of endocrine committee of FOXY way back in 2013, I had started initiative of Save the Uterus, and we had conducted 100 such programs nationwide. And my motto was to promote the medical managements of all types of abnormal uterine bleeding. And we must do every bit to an effort to save the uterus and not just simply go ahead and do the hysterectomy. We must respect every organ in the body. So I feel really happy, and really I admire the whole national president's drive that she is going through a series. I believe 3 to 4 programs have already happened in this series. So I wish you all the best for your future programs, and for this program as well. And it's a pleasure to be the guest with my dear friend, Dr. Jignesh Shah, past president of IMS, and my of IMS, Dr. Anju Soni. And we have really had wonderful time in Indian Menopause Society on national front. And I really feel that before I close my address, my last message is save the uterus, save the ovaries, save lives. And that is how we should look at fibroid uterus. Thank you so much for having.
Thank you, Suvarna.
Thank you very much, madam. Thank you so much.
Thank you. Bye-bye. Can I log off?
Yeah.
Okay,
Thank
Suvarna.
you
I would
very
have
much for
loved
being with
to
us.
listen to your talks, but unfortunately I have some other commitments here at Bombay Hospital. So
Okay.
thank you. Bye-bye.
Thank you very much. Thank you. Next, I call upon our distinguished guest of honor, Dr. Jignesh Shah, who was past president IMS 2021. He's a senior practitioner. Can I have the CV, please? Yeah. He's a senior consultant gynecologist in Ahmedabad for the last 37 years. Sir was vice president, Indian Society of Perinatology and Reproductive Gynecology 22-23. He has been an invited faculty for several national and international conferences, and his areas of interest are high-risk pregnancy, infertility, menopause, and fetal medicine.
Okay.
Over to you, sir.
So, thank you, Dr. Lakshmi, for kind introduction. And again, thank you very much for inviting me to today's webinar and making me part of today's webinar. Congratulations to Calicut Menopause Society for organizing this webinar on this very important subject, which on fibroid, which is a very common occurrence throughout the reproductive age of any woman. But its management is especially important during the menopause transition, when we are in dilemma whether to treat the fibroid medically or surgically. And with our president, very dynamic and very learned president, Dr. Sobna.
Can you please mute them?
So our dynamic and very learned speaker, Dr. Sobna, IMS president, as a speaker to speak on medical management of fibroid. And after that, the role of interventional sonography in the management of fibroid, where do we stand? These are the very two important subjects, especially in the management of fibroid during the menopause transition. And with today's deliberations, all the viewers will be having very much advantage of this knowledge in clinical practice. So, and again, one more panel discussion is also there on case discussions of different fibroids. So my best wishes to today's webinar, and thank you for making me part of this. Thank you, Dr. Lakshmi.
Thank you
Thank
for
you, sir.
coming.
Thank you very much. Next, I would like to welcome Dr. Anju Soni, President Secretary General of Indian Menopause Society. Madam is also the chairperson HIV and AIDS Committee FOXY for 22-23. She has been the past president Jaipur Menopause Society, and she is a member of the International Menopause Society. She is also the
Thank you.
trainer
Thank
for
you.
obstetric and advanced
Lakshmi, thank you very much
Okay, madam.
for your kind words. I am humbled. Thank you for inviting me today. And this topic, what Dr. Shobna has really been working hard on collecting different topics in different societies so that she doesn't leave a single, topic which is not covered in these webinars, which we are conducting all over the country and all over the societies. And today's topic is very, very close to my heart because, we all know as private practitioners that we see cases of fibroid each and every day. And, I was going through a data that it is said that every year there are more than 1 million women which are having fibroids. And especially in Rajasthan, the women get their hysterectomies done for no rhyme and reason after the age of, say, 20, 22, when they complete their family, because the marriages occur in Rajasthan at very early age. And that is one of the very, this thing in Rajasthan, the women are women are working in the fields and they don't want to work. So they go to these quacks and, MBBS doctors where they remove their uterus for, say white discharge or maybe for erosion or whatever. And their colposcopy is done. And so, when I was president of Jaipur Menopause Society, I started this thing in Jaipur for 3.5 years. That for at least Rajasthan, if not India, saving uterus is as important as saving a girl child, because removing uterus, even if you leave the ovaries behind. In Rajasthan, they don't leave ovaries also. Even if you leave the ovaries behind, scientifically it is found that these women, the ovaries function stop much, much earlier vis-a-vis the natural age of their menopause. And coming to fibroid, even if a small fibroid of 1 centimeter is seen, they are told that तेरी रथोली है, and ये बिल्कुल कैंसर बन जाएगी and blah blah blah, and the uterus is moved. So good, Dr. Shobna has taken this program, and I'm very, very happy to be here with you in this program. Of course, my Wi-Fi today is very, very bad, and I'm very, very happy that I'm meeting a lot of people, from your Calicut, Dr. Lalita Kuma, who is the chairperson, Dr. Gina, again, a very, very senior doctor who have been introduced to me, who is conducting panel, Dr. N.S. Sridevi. Nice meeting you, ma'am. As I said, I am Lakshman to my Ram, Dr. Shobna Mohandas. So thank you, Lakshmi, for inviting me over to the academic program. Let's not waste more time on these things. But I just wanted to share my thoughts because I thought it is very important to know how to manage a case of fibroid and which cases require a hysterectomy, which do not require hysterectomy, and which are to be managed in which way.
Okay.
Thank you so much.
Thank you.
Before we go on, Lakshmi, thank you, Anju. Before we go on, Lakshmi, we'll have a quick blessing from Ambuja Madam also.
Yeah. Ambuja Madam. Hello.
Yeah, I'm here.
Yeah, Ambuja Madam.
I'm here. Thank you.
Madam.
Thank you. I'm so happy to be here. More than anything, I really appreciate Shobna for taking such wonderful topics. All the topics every Tuesday, what she's taking are really good. And especially these webinars, what we are doing is the courtesy of Jignesh Bhai, and who paved the way, and we are all following. And so interesting, I'll tell you these topics. I never want to miss anything. And for that, I should be really, I should say, I should appreciate Shobana and Anju, how good work they are doing. It's not an easy thing to arrange any webinar, but still, hard work always pays for it. And thanks for inviting me and making me the part of this webinar. Thank you very much. Only one thing really what Anju told I appreciate is people unnecessarily, even 1 centimeter fibroid also, people say that it is going to become cancer. So we should give a message to everybody that it is very, very, very rare for the fibroid to become cancer. It is 1 in 10,000 also, it's not there. And especially in the postmenopausal group.
Okay.
If we can give that message, it is really great. Thanks for giving me the opportunity. Thank you very much.
Thank you very much, Ambuja madam. We now move over to the academic part of the program. Dr. Mumtaz.
Yes, good evening all. Good evening, respected seniors and dear friends. So we are moving on to the first talk of the day from none other than our dear President, Dr. Shobana Mohandas. So I would like to introduce the chairpersons. Can I have the slide, please? The chairpersons for today are Dr. Beena Guhen, Madam retired from Government Medical College, Calicut. Now she's working at the District Cooperative Hospital. She's a senior consultant there. Madam has also done her fetal medicine. It's a pleasure to have you here with us today, Madam. And next we have to chair Dr. Chandramadi. Madam is Associate Professor, again from Government Medical College, Calicut. And she was awarded the Tambai Memorial Gold Medal in 2011 and CACFO President Gold Medal in 2016. Madam has got several publications in national and international journals. And over to you, the chairpersons, to kindly introduce our speaker, Dr. Shobana Mohandas. Chandramadi Madam or Beena Madam?
Yeah, I can do that.
Beena Madam.
Beena Madam.
Thank you, Mumtaz, for the kind introduction. So as we have already heard the previous speakers about the topic, the fibroids being the commonest gynec tumor, the prevalence increasing with age, majority of them being asymptomatic, but 20 to 50% are symptomatic and necessitating treatment. And here, the treatment is definitely individualized, and here we have the options of surgical and medical management. Until recently, we never had medical options were of limited value, but novel approaches like targeting on the receptor and the gene level have come up in a very big way with a promising future. And these can be considered for even in the perimenopausal age group. That is the target here. And to speak to us today on this topic of medical management of fibroids, we have none other than Dr. Shobana Mohandas, who is the founder secretary of the Kerala chapter or the Calicut chapter of IMS and currently the national chairman.
Okay. Thank you, Beena.
It's
I
my
will
proud
share my
privilege.
screen.
Should I just read out a few?
No, that's okay. Every week I'm having webinars, so you just leave this out now. It's okay.
Okay. On to you, ma'am. Let us gather the pearls of wisdom. Thank you.
So good evening, dear Calicut, who made me reach where I am. Calicut is dear to me, and definitely I bring you greetings from my hospital in Thrissur, and I would like to speak on medical management of fibroids. I won't take too long because I'm waiting for the panel where all stalwarts in Calicut are all waiting with their difficult cases from medical colleges to teach us all what difficult things they saw. So this theory, I will just, fast skip through. Mumtaz has got a radiologist to tell us about UAE. We are wondering why UAE is taking so long to come into market. So we'll just finish this fast. Before we start medical management, there is a burning question that a lot of people are worried that fibroid is cancer, so it has to be removed. But you have to give them data that there is no evidence to substantiate the concern about malignancy, and that hysterectomy is not indicated. After that only you can talk of medical management. And so when you talk about knife, they will go to the internet and they will search and find out if there is any medical management, and they will find out there are things. And so you have to be knowing all about it. First of all, folks, see what it says. Women with subserosal or intramural fibroids of type 2 to 6 with abnormal uterine bleeding can be managed with tranexamic acid or COCs. You know what? COCs contains estrogen, and a lot of estrogen is there in that, or even NSAIDs. But Foxy is actually telling you you can use COCs in fibroids. And that was actually knowledge to me. And LNG IUS can be used. I have used it in a few subserous cases, small 2 to 3 and all that works. But the bigger ones, the fibroids, with fibroids, it does get expelled out, and there are higher rates of expulsion in medical literature also, as much as in my own practice. It does give good relief for dysmenorrhea, especially when the fibroids, they never come singly, they always come with adenomyosis. And initial prolonged periods will be Initial prolonged periods will respond to tranexamic acid. Spotting will be there for first to 6 months, and Hindus and Muslims have a little problem because they can't go to temple or their niskaram, and the prayers may be affected. Another thing is DMPA has been given by me. I've seen these prescriptions from many gynecologists, although I've not been giving it that much, but I have seen a lot of gynecologists prescribing it. It does reduce blood loss, but it will not reduce fibroids, of course. The disadvantage is that it will produce changes similar to leiomyosarcoma, although not real leiomyosarcoma, So its cellularity, mitotic activity and all will increase, and ultimately if she gets, operated, then you get scared. NETA also has been used. It also reduces blood loss and pain. If somebody wants to go to Gulf and wants 2 monthly injections, you can give these injections. It's not no. But patients do not want relief for the time being. They want the fibroid to do a vanishing act. They want it to go off. Can't you find any drug that will make it go off? The ones which are commonly used are GnRH analogs, ulipristal and mifepristone, as we all know. GnRH analogs, we know that it will reduce the estrogen levels, and when the estrogen levels are reduced, leiomyoma is an estrogen-dependent tumor. Naturally, the size has to reduce, but I have, pre-op, when you go and give this fibroids, it doesn't work that much. I have had a 28-week fibroid. They wanted laparoscopic surgery, and I gave them this fibroid. It came down to 26 weeks. Or how does it make sense? And if you have very small fibroids, it will before myomectomy, if you give this GnRH analogs, it will simply disappear. And when you're trying to go and do myomectomy, you won't even be able to see where the fibroid is. So these things are there, very big ones, because the blood vessels will not reach the center of the fibroid. This analogs and the decreased estrogen that happens with these analogs is not going to reach the center of the fibroids, and the overall size may not reduce as much as you think. And in those days when we were giving, in those days there was no mifepristone, nothing like that. And it spent so much of money on it, and after 3 months they come and, it's not reduced a lot. So that thing is there with GnRH analogs. Practically, I did not find it that useful. So it is given for 3 months. It reduces a fibroid by 50%. That's only if the fibroids are small. Quote unquote, I'm telling you from my personal experience. But longer use will have hypoestrogenic effects. Antagonists that this people use, cetrorelix and ganrelix, it will reduce the size in 3 to 4 weeks. Tamoxifen, larger trials needed. It's not really good. Aromatase inhibitor like letrozole has been tried, and there are studies on it. Anastrozole has been tried. Elagolix is an oral GnRH and activity antagonist, So what is it? It is given 300 milligrams twice daily alone, or with estradiol or norethindrone acetate to remove the hot flashes and hypoestrogenic problems in that. But the price for 1 year price is, some 1 lakh. I think 10 10 tablets ka one thing costs £1,000 or something like that. Can you imagine spending that much of money for that? So maybe it will come down in the years to come, or somebody will copy the molecule and then we will get it in India, and then maybe we can think of it. Yeah. So it is, it's with add-back therapy, it can be given for 6 months. So let's wait for someone to copy the molecule. Blood loss is reduced by 72%. Amenorrhea is achieved in 50%. And it is effective even in submucous fibroids and reduces the size of fibroids by only 15 to 20%. FDA has approved it, so somebody will copy it someday. So letrozole, the myoma volume is supposed to be reducing by 47.68%. And the uterine volume also reduces by 20. So if you have a 12-week size uterus, it may reduce to 10-week size uterus, So they had given 5 milligram letrozole, 2.5 BD or whatever, or 2 OD, whatever. So this is listed, and we are all familiar with this letrozole, so we are happy to give it. So that can also be given, but the side effects are there, and the love affair between the patient and the doctor will go if there are side effects. And so what are the side effects? They are commonly hot flashes in more than 60% of patients, headache, insomnia, memory disorder. That happened. I mean, anyway, we forget your pen and mobile phone and everything everywhere. Nobody will think it's because of the drug. Significant bone mineral density losses there. That also you won't realize it. So that only, later on you'll realize after a long time. Arthralgia, myalgia, alopecia, dyspareunia, vaginal dryness, that they will definitely come back and talk to you. Rarely vaginal hemorrhage and allergic reactions. These are the side effects. And so the patient will, if they have too many side effects, they will go to the mobile phone. Just like in a supermarket, they will go shopping with all the doctors. And so you need better molecules. So estrogen and progesterone, they have growth factors, cytokines. All these things will increase the size of the myoma. So something that can block the progesterone, blocking estrogen is usually done by progesterone, that is not going to work for this leiomyoma, but something that blocks the progesterone will really work for a leiomyoma. And therefore, whatever blocks the receptors at which the progesterone acts, selective progesterone receptor molecular, so those are the ones which are going to help. One is ulipristal acetate. It comes in the market, goes out of market. It's again come back into the market. So it is known as a selective progesterone receptor modulator. It reversibly blocks the progesterone receptor in its target tissue and acts as a potent orally active anti-progestational agent. But you can only buy time. Once you stop it, it will again come back. It reduces bleeding within 7 days. At least patient is happy. Estrogen levels are maintained, so no hot flashes. And the coming back to pre-treatment levels is delayed, So 13 weeks, the size will reduce. The dose is 5 to 10 milligram. 5 is good enough. So this is what happens. After course 1, you give 3 months course, then it will reduce to 38%. Then you give 1 month holiday, give the second course, again it will reduce to 53%. You give 1 month holiday, take the third course, it will reduce to 60%. So almost 70% it will reduce by the end of the year. Each month, probably around 3,000 rupees or something that patient will have to shell out. And by the end of the year, one year is a good buying time. In between, if she goes into menopause or she can plan something else, it's good enough. So 3 months on, 1 month off, 3 months on, 1 month off, and the size will reduce to 67%. There is no increase in occurrence of more serious conditions of the endometrium like hyperplasia with atypia or endometrial carcinoma. Serious liver injury was there, and that's why it was withdrawn from the market. So you have to once in a while call the patient for liver function test, check the transaminase level, and you have to tell the patient you can't run away. Please come back and do your LFT. I know you won't get it, but still please be on the safe side, do your LFT. There are other drugs. And I won't be going through all this because most of you are not going to be writing exams, and I don't think all these examiners will cut their marks for not writing all this. So we'll just go through common things. Mifepristone, it is a progesterone receptor modulator. It was there in the 80s as an abortion molecule. We have been giving it. It may directly decrease the progesterone receptor in the myometrium. The dose is 25 milligram daily for 3 to 6 months. And reduces blood loss and pain. That's one thing. Size of the fibroid is reduced by 12 to 21% by 3 months. Don't expect it to go by 1 month, so you have to tell the patient you have to take it for 3 months. Amenorrhea is seen in 90% of patients. That's why the patients are very happy. You give them and then you see them on the corridor somewhere. What happened to you? You never came back to me. Doctor, I don't have any bleeding now. Why should I come back to you? So what to tell them then? They're happy and they don't want to come back to you. So, but now unlike ulipistol, endometrial thickness increases by 24.8. There is a simple hyperplasia and there is little transaminase increase in 7%. But the basic problem is next time they will go and do the scan and the endometrium is increased and you start getting worried. You do a little biopsy and then you again start worrying, oh, simple hypoplasia. But if you decide that this is a side effect of mifepristone, then you don't have to worry. So if you know there is a problem like this, you don't have to worry. And there is some cystic glandular dilatation noted at this dose. And it is reassuring that there is no hyperplasia or atypia, then you should be reassured and you should be happy. Don't get scared of it. So in short, if in a young woman who wants to preserve it, give up to 4 courses. If there is a satisfactory response, start pursuing conception without myomectomy. No desire for pregnancy, monitor and restart if the symptoms recur. When you stop after 1 year and wait for 3 or 4 months, and by that time, like if things are okay, a lot of people when after delivery, the fibroids decrease and they disappear. Now, I've seen it many times. So something like that happens, we are happy. What about perimenopause? There is pain, you give NSAIDs and ulipistol. And otherwise, hypermenorrhea, you give it. Follow up for 6 to 8 months. If the symptoms recur, in the older age, you can still try UPA. In the younger age, less than 45, how long you'll go on giving this? 40-year-old girl coming like this, year after year, you can't give. Then you please do the hysterectomy or ultra UAE or whatever you want. Danazol, the old drug, it can actually reduce the uterine volume by 24%. Did you ever think of it like that? Other drugs like cabergoline, we have all been giving it in our infertility practice. You know that? Actually, in the women between 20 and 40, there is a study, not in perimenopausal women. Maybe we can try it out also in that group, no? You know what it does? Prolactin receptors have been identified in the myometrium, and their amount is different in different myomas. Some people will have prolactin receptors. So in some women, at least, this cabergoline will really help. So if you're happy, you're not happy with letrozole, you're not happy with your mifepristone, so costly, maybe out of the box you can think and give cabergoline. Patient will be happy. So there is a study which says that it's as good as a costly GnRH agonist, in lowering the size of the myoma. They had 26 women in the case group and another 26 in the control group. And the uterine volume size and everything were lower in the case group. So for your poor patient group, where they are definitely adamant that they want to reduce it, please try it out. I mean, there's no harm in trying. There are studies on it. So one thing is after menopause, it will resolve. So when will you really actually wait? There is a length of perimenopause transition is very few months. And the average age of menopause is 46 plus or minus in 5. So you can wait, for a few months. When that perimenopause, you tide over with all your medical treatment, whether it's your ulipistol, cabergoline, letrozole, GnRH, or whatever you want, you try it out. But in between, some patients will come with hot flashes with fibroids. Can you give HRT? There are no good studies, but some studies show increased rate of fibroids. But it is triable because there are studies where they say that the fibroid size may increase, but they don't become symptomatic. So it's good enough. So what if it increases in size? So you can try it out. So I have quickly finished my talk to conclude. In women who are willing for follow-up, medical therapy for fibroids is a feasible option. Progesterone therapy, OC pills, injectable progesterones can reduce bleeding to buy time. Ulipistol and mifepristone are good options. For the poor people, cabergoline has been tried in younger women. Try it out in older women. Thank you so much. And I hope, I'm sorry to be finishing too fast, but I don't want to delay. Everybody knows everything, so I didn't want to repeat. Thank you so much.
Thank you, madam. Am I audible?
Yes, Dr. Chandramati, you are very audible from the medical college.
Thank you, Dr. Shobana Mohandas, for the elaborate talk on medical management of fibroids. Previously, we know we had only surgical treatment for fibroids, but now we are having so many options. At least we can give a treatment for a short course, so the patient will be satisfied, the consultant will be satisfied for the medical treatment, and they will, and especially when we are giving this treatment with the mifepristone, as madam said, after 3 months they will be happy because they are having amenorrhea, no blood loss. They won't be fed with this menorrhagia, and they are very happy. So the options, so many options for medical treatment is available now. So thank you, madam, for that elaborate talk. And I think the topic is open for discussion. Can have the discussion now itself or at the end of
anybody wants to speak up, because we are on gallery view, so anybody can just unmute and speak for 1 or 2 minutes and their experiences in the audience. Anybody wants to talk on?
Yeah, madam, I have a question, madam, about your personal experience with ulipristone. Do you have?
I have tried it out, but not much reduction in size was there. But the bleeding did decrease a little bit.
Is it the cost factor that was keeping you back?
Yeah, and the fact that on stopping it again, it will come back. No, that's the main thing. People who are really badly symptomatic, then and if they're not perimenopausal, how long will you go on giving it? And it's really such a costly drug, and you cannot give a guarantee that it will really go away unless they are perimenopausal. I've given it for 3 months, but when I counsel the really symptomatic patients, I could not really convince everybody for ulipristone. Ulipristone and mifepristone, maybe some 500 rupees difference. Is there not much difference? Some of them are agreeing for mifepristone. And ulipristone went out of market also, no, for some time. Yeah. For 1 or 2 years, it went out. Now again, it's come back. Now we have to really start thinking again. Thank you, ma'am. You have any experience,
tell
Meena?
one thing, whatever is said and done, with the very symptomatic fibroids, they don't like to have the medical line of treatment because nothing is going to be helpful for them. Once you stop treatment, either injectable or oral, whatever it is, again it comes back. The symptoms will come back. So
Son's marriage,
just to buy
daughter's
the
marriage,
time,
all
that's
that they
all.
will take.
But most of the times it is only the surgical methods will be there. Where, see, you don't need to do hysterectomy for everything, but there are other surgical methods. As far as the medical methods are concerned, I'm not very happy. Just to buy the time, it is very good.
Yeah, find out. Medical management mainly helps us to buy some time to correct anemia. Many patients who are anemic, we don't want to give them blood transfusion. We will get some time. They will become amenorrheic, and we can buy some time to correct anemia if they are really symptomatic. In asymptomatic fibroid, less than 14 weeks, actually, we don't have to give any treatment. You can just follow them up. Then regarding ulipristone, one point, already Dr. Shobana has told, the endometrium will become very thick and we'll be afraid of seeing the endometrium. And if you do an endometrial aspiration for such a patient, you will be getting tons of endometrium. Large, thick, fleshy. You may think it is even malignancy. Such a gross, really dreadful endometrium you will be getting. So there is a problem with ulipristone. Others, GnRH is definitely useful for the correction of anemia. That's what I have found in my practice.
My experience, my experience with ulipristone and mifepristone danazol, just like Dr. Shobana said, has been quite good. Only thing is, what is the protocol with cabergoline? That is
0.5 milligram per week.
Just 0.5 milligram per week will
not even twice a week. Normally, what we give for hyperprolactinemia, it's just that much also you don't have to give. It's 0.5 milligram per week.
Okay, thanks.
How long? How much reduction?
Maybe 2 or 3 months. That study was for 3 months.
3 months is the standard management to check, evaluate the size of the fibroid as well as the endometrium.
Yeah.
Thank you.
See, ulipristone is nearly 12,000 for 3 months.
Yeah, yes,
And
Deepa from
nifedipine
Lucknow.
is just 1,500 rupees per month. So it is
Yeah,
much lesser than ulipristol.
Ulipristol. That's why I said,
And,
try it
and
out. I don't know how much it will
definitely
work, but we can try.
even in females who are say even like 40 years or so, we have had patients who have completed their family also, but still they wish to go in for a myomectomy. If it's a single myoma, it is pressing on the bladder or on the rectum. With a myomectomy, you can help them out. There's no harm in going in for a myomectomy, even at 40 also, at least you're saving the uterus and her ovaries, everything. So that will be a cheaper solution rather than giving ulipristol, going on giving it for 3 months, 6 months, 10. So that way you can help the patient more by doing a myomectomy rather than going in for a hysterectomy.
Okay, thank you, Deepa.
Madam, the chairpersons for that wonderful.
Okay, now Mumtaz.
Yeah. Thank you, madam, for your dynamic, power-packed presentation as usual. And thank you, chairpersons. I think there are no more discussions happening now. Shall we move on to the next talk? I would request our chairpersons, Dr. Lalitambika, madam. Can I have the slide, please? Please share the CV slide. Madam is a former professor and head of the department from Government Medical College, Alappuzha. And Madam has done a lot of work in the field of ultrasound also. And the other chairperson is Dr. Gina Baburaj. Dr. Gina is a consultant from Vadagara. She is also the chairperson of Oncology Committee, Kerala Federation of Obstetricians and Gynecology. She is also in the editorial board member of ISCP, and also the founder president of WDW Vadagara. Over to you, the chairpersons, for introducing the next speaker, Dr. Taufik, intervention radiologist.
So, let me introduce Nirambia madam. Let me introduce him.
Yeah.
And now respected senior members. And first of all, I must thank Dr. Rashmi for giving me this opportunity. Now in people in around the Kerala, people are more concerned about saving their uterus. And today also 2 patients asked me, Madam, you have this, are you doing this embolization? So I am ready to hear from you, Dr. Taufik. I know that more people are going to this Kottakkal and to Pendalmanna for embolization procedures. So this Dr. Taufik is an interventional radiologist from working in Pendalmanna, Malappuram. And he did his MBBS from KMCT Medical College and MD Radio Diagnosis from PG Postgraduate Institute from Chandigarh, senior resident of Maulana Azad Medical College. And now I invite him to present the topic. So Dr. Taufik, the podium is yours.
Thank you, ma'am. A warm good evening to all the past and present office bearers of Indian Menopause Society as well as the Calicut branch. Good evening to all the attendees. And now I will start my presentation. My topic for today is uterine artery embolization. Where do we stand? So first of all, I don't have any disclosures, no actual or potential conflict of interest in relation to this program or presentation. So I'll give a brief overview of what I'm going to present today. So I'll give a brief history of uterine artery embolization, how it evolved over time, the indications of the procedure, as well as the contraindications. What are all the pre-procedure evaluations that are needed before doing this procedure? A brief angiographic anatomy of the uterine vasculature as well as the technique. The choice of embolic material that we commonly use for the procedure, complications, as well as follow-up after uterine artery embolization. So the first uterine fibroid embolization was done in Paris, France. It was done by Jean-Jacques Merlard, who was a neuroradiologist, as well as a Jacques Ravina. She was a gynecologist. So they did initially for reducing the bleeding during myomectomy, they did a prophylactic uterine artery embolization. So, and later it became, for them, it was evident that just by doing a uterine fibroid embolization, the fibroid size significantly decreased, and there was significant symptom improvement in those set of patients. So they did a study in which they could achieve 100% technical success for embolization. And on follow-up, they observed that 11 patients who they enrolled had complete response. That means they had complete symptoms where they were relieved of symptoms, and 3 had partial improvement of their symptoms, and there were 2 failures. And following which, the first uterine fibroid embolization in US was done by Scott Goodwin, and he also published his data in the Journal of Vascular and Interventional Radiology, where they obtained a complete response in 8 patients of a total 11 patients. There was 1 failure due to incomplete embolization, and there was complication also they encountered, was infective complication of endometritis. Following which, a lot of trials happened in uterine fibroid embolization, where we are one of the major studies that happened was the REST trial. It was a randomized multi-center study in the UK, where they enrolled 106 patients, and they were divided into 3 sets. 2 who underwent uterine fibroid embolization, 2 of the 3 underwent uterine fibroid embolization, and 1 underwent surgery. So total of 106 patients, 51 patients underwent surgery, and 106 patients underwent uterine fibroid embolization. So they divided the results as a short-term improvement of symptoms as well as a mid-term result. So in the short term, the results were great. So there was the uterine fibroid embolization had a shorter stay in the hospital, and it was less painful for the patient, as well as they were able to return to daily activities within a very short amount of time, where the p-value was very less, and it was very statistically significant results they got in favor of uterine fibroid embolization. In the midterm result, as you can see here in the last, uterine fibroid embolization was associated with, was more likely needing a re-intervention. Mainly after a period of more than 3 years, they had a chance of, to undergo re-intervention in the form of a re-embolization or other surgical methods for the symptom control. So these were all the studies through ages of time from the year of 1997. The main study that had happened in this uterine fibroid embolization was the Fibroid registry. It was done in 72 centers in UK, and where they could obtain 87.3% success, clinical success in the form of symptom reliever. And one other study was published in American Journal of Radiology. The study was done by Katsumori. They had symptom control in 89.5% of the patients who underwent uterine fibroid embolization. And long-term studies, which was done within a period of, after a period of 36 months or 3 years, had a symptom control of more than 80%, of approximately more than 80% in all the studies. So one other trial which compared the pregnancy outcome between uterine fibroid embolization and myomectomy after a period of minimum of 12 months and a mean of 24.9 months was the Prague trial. They enrolled 121 patients. They enrolled 121 patients, in which 63 patients underwent myomectomy and 58 patients underwent uterine fibroid embolization. And there was statistically significant pregnancy rate was higher in patients who underwent myomectomy as compared to uterine fibroid embolization. And also delivery and abortion rates were lower in uterine fibroid embolization. Both were, all these 3 were statistically significant. So this, so after this study, it was made, it was nearly concluded. So although it needed more randomization and more studies, it was nearly concluded that myomectomy had a better pregnancy outcome compared to uterine fibroid embolization. So this data was published in 2008 in the Cardiovascular Interventional Radiology Journal. So basically uterine artery embolization, there are many indications for uterine artery embolization. They include uterine leiomyomas or fibroids, adenomyosis, in which most of the uterine fibroids are coexisting with adenomas in approximately 20 to 30%, uterine AV malformations, and postpartum hemorrhage. So coming to uterine fibroids, major symptomatology of a fibroid, the patient presents with heavy regular menstrual bleeding. And if it is irregular or if there is intermenstrual bleeding or metrorrhagia, caution is advised, because other causes of heavy menstrual bleeding should be avoided, should be ruled out before going ahead with the treatment of uterine fibroids. And other pressure symptoms, pelvic pain, and infertility are also the presenting symptoms of a fibroid uterus. The pressure symptoms are related to the size and location of the fibroids, and infertility is related to the distortion of the reproductive tract, as well as the fibroids. They act like a foreign body within the reproductive tract and causes infertility. So pressure symptoms, long-term improvement is there after uterine fibroid embolization. There is long-term improvement. Definitely for one, like hydronephrosis, there was one study which showed nearly 100% of the patients who were enrolled in the study had resolution of hydronephrosis after uterine fibroid embolization. In general, infertility, it should not be the first. Uterine fibroid embolization should not be the first line of treatment for women with infertility. And fibroid-induced infertility only if the patients are not candidates for surgery must be considered for uterine fibroid embolization. As the Prague trial has already shown us that pregnancy rates were higher in patients who underwent myomectomy compared to uterine fibroid embolization. So who all are the ideal patients for UFE? So this ideal set of patients, these are the patients, they have better patient symptom control as well as post-procedure satisfaction after uterine fibroid embolization. So identifying this set of patients is very important, because these patients will have better outcomes after the procedure and they'll be more happy. So these are the premenopausal patients who have completed their family and are not desiring for future pregnancies. And postmenopausal patient with failure of spontaneous regression of symptomatic fibroids, as well as symptomatic fibroids after failure of medical management, and there is a contraindication for surgery. So these are the three sets of patients who are going to get benefit from uterine fibroid embolization the most. So coming to contraindications of the procedure, there are only very few absolute contraindications, which include a current pregnancy. There is a known or suspected pelvic infection or bacteremia, known as suspected gynecological malignancy. So all these should be ruled out initially before uterine fibroid embolization. And the relative contraindications include coagulopathy, renal failure, allergy to contrast, PVOD or peripheral occlusive arterial disease, currently on hormonal therapy, GnRH agonist, because GnRH agonists, they will cause the regression of blood vessels within the fibroids and also in the uterus. So it will lead to inadequate embolization of the material, so that the patient will have recurrence of symptoms if the hormonal therapy is not withdrawn in time. And also pedunculated fibroids, they were considered a contraindication initially, but subsequent studies has revealed that if the stalk width is less than 50% of the size of the fibroid, or absolute size of less than 2 centimeters, that only is the contraindication. If the stalk width is more than 2 centimeters, we can safely go ahead with the uterine fibroid embolization. So the pre-procedure evaluation consists of the cancer screening, basically to rule out endometrial, cervical, as well as other leiomyosarcoma like malignancies within the uterus. So a pap smear is advised. It should be carried out within 6 months of embolization, and biopsy, report of which should be available within before 12 months of procedure. Routine serum parameters like RFT-CBC, beta-HCG levels to rule out pregnancy, coagulation profile, as well as an imaging evaluation. The preferred imaging modality for before uterine fibroid embolization is MRI or magnetic resonance imaging, because they can characterize the fibroids based on the location, number, as well as if the fibroids are viable or not. So basically, if the fibroid is non-viable, or if the vascularity is very less, the patient is not going to get any relief of symptoms after uterine fibroid embolization. So identifying these set of patients and counseling them before the procedure, or counseling them to undergo other options is a good option, because MRI helps us to delineate all these types of degeneration that has happened, whether the fibroid is viable or not. All can be delineated from an MR imaging. So findings pertaining to success of uterine fibroid embolization include a pedunculated leiomyoma. As I've already said, if the stalk diameter is more than 2 centimeters, we can safely do a uterine fibroid embolization. There is, if it is a submucosal fibroid with a short stalk, there is a chance of transcervical expulsion or obstruction, which may require additional treatment options like removal of the fibroid within the endometrial cavity, etc. And the patient should be counseled accordingly. And submucosal leiomyoma, if the interface to diameter ratio, we call it ID ratio, assessment should be carried out for any submucosal leiomyoma before the procedure. So if the ID ratio is more, there is a more chance of transcervical expulsion of the fibroid after embolization. And as I've already mentioned, non-viable leiomyomas are the myomas that are not enhancing, and they are not ideal candidates for uterine fibroid embolization. And coming to cervical leiomyomas, they are also not very good candidates for embolization because they have alternate or additional blood supply, like the cervicovaginal branches, or they can recruit blood vessels from so that after the procedure, symptoms may not come down as the patient expected. Adenomyosis is coexistent in 15 to 23% of the patients, and this may cause initial symptom relief is good in adenomyosis for after uterine fibroid embolization, but long term, say for example 3 to 5 years, the symptoms can recur and it leads to treatment failure. So identification of adenomyosis is an important step for doing uterine fibroid embolization. So, I've already said malignancy, the ruling out malignancy is a big challenge. So the Society of Intervention Radiology guidelines in 2014 states that the radiologist should inform the patient the possibility of a misdiagnosis of cancer and delay in definitive treatment before commencing the process for uterine fibroid embolization. Also, the 2009 Society of Intervention Radiology stressed the importance of informed consents by informing the patient regarding the other surgeries or gynecological alternatives, the choice of embolic agent, the route of vascular access that they would prefer, and the use of arterial closure device in some set of patients in which complications may arise. So all these should be informed to the patient and discussed with the patient thoroughly before commencing the procedure. So coming to the arterial anatomy, so in 45% of the cases, uterine artery arises from the inferior gluteal artery as a first branch. Sometimes there is a trifurcation of superior gluteal, uterine, as well as inferior gluteal branches in approximately 43% of the cases. So it is the first or second branch of internal iliac artery. It has a L or a U course. Descending segment is there. There is an arch. There is an horizontal segment, and there are descending cervicovaginal branches which should be preserved. And intramural branches which supply the fibroids usually, and there is an anastomosis between the contralateral uterine artery as well as the ovarian branches. So these are the axes that we commonly take. The common ones are the femoral artery that have been used in the past. So currently there is a slow paradigm shift towards radial and brachial axis so that the patient will have better post-procedure compliance. So this is just the pelvic angiogram, which shows the internal iliac artery, its branches, uterine artery supplying the uterus, as well as the supply of the fibroids. So technique is the uterine artery is accessed using a catheter as well as a microcatheter in a coaxial technique. And after the cervicovaginal branches are given off, the uterine artery angiogram is performed to ensure that the cervicovaginal branches are preserved, and embolization is started using embolic material that I'm going to discuss in the next few slides. And once we get a prune tree appearance where all the cervical intramural branches and cervical vascular supplies almost cut off, that is the end point, that when we stop embolizing the uterine artery. So embolic materials, I have said, currently the FDA approved ones include embosphere or triacetyl gelatin microspheres and PVA particles. These are the sizes of the embolic agents that are commonly used. The size of the embolic material depends on whether there is anastomosis between the ovarian artery and uterine artery. And if we do a uterine artery angiogram, if the ovaries are also being supplied from the same uterine arteries, then we would prefer a larger particle size so that there is no ovarian ischemia, and there is risk of premature ovarian failure is reduced. So PVA particles are the ones that have been used in the past, has the longest experience. They are inexpensive, but they are hard to inject, and there is a chance of proximal occlusion of the uterine artery. Even before the distal bed of the fibroid is occluded, there's a chance that the proximal arterioles are occluded, so that they will incite more inflammatory reaction, and responses, or the patient will have symptoms may recur in those set of patients. Whereas embospheres are the first FDA approved particles. They are more expensive. They cause more distal occlusion, and they have by using embosphere, we have better control of endpoint. So coming to vascularization of a uterine fibroid, always this unilateral embolization will not help in relief of symptoms or decreasing the size of fibroids. So always the bilateral embolization is preferred. And if utero and ovarian anastomosis is visualized in an angiogram, choose the particle accordingly so that ovarian embolization is risk of ovarian embolization is decreased. And sometimes the fibroid may completely be supplied by an ovarian artery. So in those cases, like they happen in patients who had previous pelvic surgeries, like myomectomy or cesarean section, who had tubo-ovarian pathologies like salpingitis or previous tubal surgeries, or they are having simply large fundal fibroids. As you can see here, this is the ovarian artery coming from the aorta. This tortuous ovarian artery is completely supplying this fundal fibroid. So in these cases, ovarian uterine artery embolization alone will not cause regression of size of the fibroids. So this is the size of the ovarian uterine vascular network, as I've discussed. So depending on this, we choose the embolic material as well as the size of the embolic material that can be used in a particular set of patient. So this is the end point of embolization in a patient that we have done. Cervicovaginal branches are preserved, and there is no further blush within the uterus or within the fibroids. So coming to the complications, common complications associated with uterine fibroid embolization are puncture site hematomas, can be femoral if the femoral site is used, or radial or brachial hematomas, brachial site hematomas, and post-embolization syndrome that is also commonly encountered, in which the patient experiences pain, pelvic pain, low-grade fever, and nausea and vomiting because of the inflammatory reaction, and expulsion of fibroid, which is encountered in 2.5% of the patients who have submucosal fibroids. Other complications less commonly encountered are non-target embolization leading to premature ovarian failure, bladder necrosis due to embolic material entering the vesical branches of internal iliac artery, and infective complications. They are the most dreaded ones. Infective complications like endometritis, tubo-ovarian abscess, pyomyoma, and uterine necrosis. So as I've said, the post-embolization syndrome consists of the pain. So to enhance the patient comfort, initial management is necessary, aggressive management is necessary, so that the patient will be can be made ambulatory as soon as possible, so that the risk of DVT and thromboembolism is minimized. Infective complications, always we should watch for infective complications and differentiate it from the post-embolization fever and pain. So always if the patient pain is persisting, we will go ahead with an MRI, and aggressive antibiotic and drainages should be done if already an abscess has formed, and it may end up in hysterectomy if the infection is not controlled by non-invasive methods. Expulsion of fibroids happen in 2.5 to 3% of the cases. It may continue for several months after embolization, and usually it passes on by itself, and it leads to extensive remodeling of the uterus. So after follow-up, if the patient has passed out a lot of fibroids, in the follow-up MRI, we will have drastic change in shape and size of the uterus, as already the fibroids have been expelled. So does the number of fibroids affect uterine fibroid embolization. How much should be the number of fibroids for a patient who can safely undergo uterine fibrosis? There is no cutoff. As such, there is no cutoff for number of fibroids. Only thing is that the overall uterine size should be less than 24 weeks. And it does not increase the risk of complications, even if the uterine fibroid number is high. And it does not affect the technical approach also. And efficiency of uterine fibroid embolization will stay the same. Does the size of a fibroid affect uterine fibroid embolization? The answer is no. But if the size is more than 10 centimeter, if the uterine size is more than 24 weeks, then there is a disadvantage for for uterine fibroid embolization, because there is limited shrinkage, and embolic agent that we require will be more to reach the end point of embolization, as well as the radiation exposure. And this all will increase if the uterine size is very high. And usually we perform uterine fibroid embolization only if a uterine size is less than 24 weeks and single fibroid size is less than 10 centimeters or 100 cubic centimeters of volume. And also the complication rates will be higher with increasing leiomyoma size. These are based on studies that have come up in the year of 2003 and 2008. So follow-up after uterine artery embolization, usually what our hospital follows is a follow-up MRI after one month of time. And the goal of follow-up is to achieve 100% infarction of the uterine fibroid. So we give a contrast, we do a contrast enhanced MRI pelvis to see if there is any residual myoma tissue that is still enhancing, so that there is a chance of regrowth of these portions of the fibroid, so that the patient can have residual symptoms or may have recurrence of fibroids in near future or in long-term future. Some hemorrhage and air within the fibroid is expected, and calcification may occur usually after 6 months time. And we should look for complications, infective complications like formation of abscesses, pyomyoma, that is pus within the fibroids, pus within the uterus. And usually asymptomatic patients, after a single follow-up, we usually doesn't do a imaging follow-up until the patient is asymptomatic. So coming to conclusion, uterine artery embolization is a safe and effective procedure for symptom control in uterine fibroids. It is minimally invasive. It is done in an outpatient manner for most of the patients, and the patient can return to normal activity in about 1 week time. And reintervention rates are lower. However, they are reintervention rates are more compared to myomectomy and hysterectomy. But with time, as I've said, by 3 years, 4 or 5 years after doing a uterine fibrillation, reintervention rates are higher. And clinical studies have shown equal symptom relief compared to surgery, with less recovery time and complications. So most important thing is a multidisciplinary management approach that should be undertaken by a gynecologist and radiologist regarding the choice of treatment, as well as the choice of the patient. And the patient selection for a uterine fibroid embolization is very important for the success of uterine fibroid embolization by correct imaging, diagnosis, and localization, finding the number, identifying whether the fibroids are viable or not. And also, I would stress on the post-procedure follow-up, correct post-procedure follow-up, and early identification of complications are very critical, so that the patient will have better outcome and response. Thank you.
Thank you, Dr. Taufik. That was very informative. Over to the chairpersons.
Hello?
Yes. Ma'am, you are audible.
Yeah. Okay, thank you, Dr. Taufik, for a very clear, crystal clear presentation about uterine fibroid embolization. And most of the gynecologists
Please
are
stop
unaware of...
slide share.
Huh?
Evelina, please stop slide sharing.
Okay. Most of the gynecologists, though we have heard of uterine artery embolization, we never knew about such details, and very few people are regularly doing it. I think in southern part, very few people are doing. In northern part, our Noto centers are doing. And Dr. Taufik, we would also like to know about the incidence of these complications that you encounter in your practice. When we counsel patients, we have to be very much aware of these complications.
Ma'am, the complication rates are very low compared to early complication rates. The late complication rates in terms of recurrence of symptoms, they are a little higher in uterine fibroid embolization. The complications like hematoma, infection, as well as the fibroid expulsion, these are all very less. Even the fibroid expulsion rate is 2.5%, and infection rate is as low as 0.5%. So these are all the complication rates, and hematoma rates are very less because of our newer ultrasound guided techniques of vascular access. These complications occur very rarely. But recurrence rate as well as the patient non cessation of the patient symptoms, these are all the complications that should be explained, that we usually explain the patients regarding this, because even after uterine fibrosis, the patient may have still the pressure symptoms. It take some time for the patient to get relief of the pressure symptoms. So these are all the main complications that happen very commonly. The complications that are life-threatening happens very in very few patients only, like DVT and thromboembolism have been reported, but they are seen in very few patients.
What about life-threatening sepsis? Most of the gynecological textbooks say submucous fibroids you should not do because there's high risk of sepsis.
Ma'am,
you have explained when the diameter of the pedicle is, that we understood, but is it very accurate? By MRI, you assess the size of the pedicle.
Yes, ma'am. Yes, ma'am. If it is pedunculated, we can accurately assess the stalk size. So initially, it was said the stalk should be less than 50%. We should not do embolization. If the diameter of the stalk is less than 50% of the fibroid size, then we should not go ahead, because there is a chance of separation of the fibroid. If it is subserosal, it can have it will be left out in the pelvis, and patient may require surgery later. So but now recent studies have shown that if the stalk size is more than 2 centimeter, regardless of the fibroid size, we can go ahead with embolization. And risk of infection, ma'am, we usually give prophylactic antibiotics. We start the antibiotics just before embolization, because any embolization, we are making that field very avascular. So if there is a chance that some infective focus have already seeded the uterus, there is a chance that patient can develop endometritis or pyomyomas and all. So, but prophylactic antibiotics have drastically reduced the infection rates after uterine fibroid embolization, ma'am.
And how do you remove that fibroid if it gets submucous fibroid into the endometrial cavity? The stalk sloughs off and it is left in the endometrial cavity.
Ma'am, usually it passes off. The patient will deliver the fibroid by herself. And if sometimes in very few cases, we have seen the fibroids getting stuck within the endometrial cavity and causing obstruction. So in those cases, intervention may be required. Maybe the patient may end up in hysterectomy also.
Okay, thank you, Dr. Taufik. I think not only me, most of the audience might have benefited a lot from this talk, because there are so many points which are very clearly explained.
Thank you,
Madam. Dr. Shraddha Agarwal wants to say something. She's raised her hand. Can we have a minute for her?
Yeah. Dr. Taufik, can I ask you a question? What is the cost to the patient for a sitting?
Ma'am, it depends on how much embolic material we use. So if the uterine size is very less, the embolic material that we use is very less. So in my hospital where currently I'm working, it comes up to about 75,000, including the cost of an MRI that we do prior to the procedure, as well as the hospital stay, the procedure itself, as well as the discharge formalities. And it may go up to 1 lakh depending on the size of the fibroid, as the number of the particle bottles. If you use more, the rates may go higher.
Has there been a need for repeating the procedure in the same patient?
Ma'am, usually only after 3 years. I've encountered few patients after 3 years. During my residency, I've seen re-embolization being done. That was because of the supply was coming from the ovarian artery. So it was a large fundal fibroid. All the other fibroids shrunk in size. Even the uterus had shrunk in size, but the fundal fibroid remained as such. So they had to be tackled via ovarian arterial approach.
Thank you for that excellent presentation.
Thank you.
The risk of premature ovarian failure, is there any case of premature ovarian failure encountered?
Yes, ma'am. There is that's why I stress upon MRI being used before the procedure, because if there is the anastomosis, even during the angiogram, if we see ovaries being opacified after doing a uterine artery, if we give contrast in the uterine artery, if you're seeing that ovarian vessels being opacified by doing a uterine, it means that there is an anastomosis, prominent anastomosis within the ovarian artery and uterine artery. So what if we give the particle size, smaller particle size, these particles can go and occlude the ovarian artery itself and the distal branches of ovarian artery, so that there is a chance of ovarian failure, premature ovarian failure in that situation. So if we encounter an ovary or ovarian artery by doing a uterine angiogram, we should choose the particle accordingly, so that the particle won't go into the ovarian bed as such. So the higher particle sizes are chosen if there is an ovarian anastomosis that is identified on angiogram, on table angiogram. And also the MRI will help if we can clearly delineate doing an MR angiogram, if you can see ovarian artery prominent coming in an anastomosis of the uterine artery, then that should raise the alarm that the particles that we are going to use should be as such, so that the patient may not encounter a premature ovarian failure.
I would like to just share one case, few cases, because I'm from Hyderabad, and it's a Yashoda hospital. It's a tertiary care hospital. So here what we have done is patients who had this cerebrovascular diseases on anticoagulants. Those cases we did this uterine artery embolization, and I think the results were fantastic. And the patient was so happy that her bleeding pattern has come down, and she used to get her blood transfusion done earlier when this procedure was not done. I think it is one of the wonderful procedures for such patients where we can't do a surgery.
And I would like to add, ma'am, for wall replacement patients who are on warfarin, who can't undergo surgeries also, these subset of patients are also going to get benefited much better.
Yes, I agree. And the cost is nothing for them, even if it is very expensive, though procedure. Some people may think that just embolization is so expensive. But I think in these patients, it's really worth.
Yes, ma'am. I agree, ma'am.
Dr. Taufik, it's an excellent presentation. So I learned
We're
a
running
lot
out of time.
from the presentation. Yeah.
Thank you, ma'am.
And so patient selection is the important point in uterine embolization.
Yes, ma'am. Yes, ma'am. Definitely.
Thank you, Taufik, for that wonderful talk. Very informative for all of us. Thank you again. Thank you, chairpersons, for being there. Thank you, Jamina Madam, Lalidambika Madam, for your inputs. Shall we move on to the next session? I would like to introduce Dr. Sridevi. Dr. N.S. Sridevi. Sridevi, Madam, slide, please. Madam is a teacher of most of us from Kerala sitting here. Madam has worked in all medical colleges, and she was also the professor and HOD and Calicut Medical College. She retired from Calicut Medical College in 2007. And Madam is currently working in Pushpagiri Medical College. She is the head of the department at Pushpagiri Medical College, Tiruvalla. And Madam got the Best Doctor Award from IMA in 2007 and has many national and international publications. Over to you, Madam. Sridevi, Madam?
Yes, I'm here. Okay, I have to share the presentation. No? Okay, very good evening to you all. Respected President, Dr. Shobana Mohandas, Dr. Lakshmi, President of Calicut Menopause Society, Dr. Mumtaz, Dr. Santosh, everyone, good evening to you all. And the topic for today's presentation is Sorry. Opening. Sorry, it is not opening. Take a minute. Okay. Yes. Visible, no? Slides are visible.
Madam, not yet.
Madam, slides are not visible.
Okay.
Madam, have you clicked share screen?
Yeah.
On the PowerPoint presentation of yours, you have to click share screen on the right-hand top corner.
Giving that, but it is not. Can you see now?
No, madam.
No, madam.
Now?
No, madam.
No, madam. No, madam.
Why?
She must have gone to some younger person to help her out.
Just a
We
minute.
all do that.
Just a minute. Share screen. It is not seen there. Okay, it is not seen.
Sir, there is one green button, share screen, with an arrow on the pointing upward. At the bottom of the window, there will be a.
No, I know that.
But it is not.
Is somebody else sharing the screen right now?
Just 1 second.
It's not coming. Even if click, I'll click it, it is not coming.
Is Taufik share screening switched off?
Can you speak without this presentation, madam? You can just ask questions,
Okay,
they will
1
answer.
second.
No,
Just
no,
hold
no.
on, just
It
hold
is
on.
all case presentations. What they have
No,
given.
you can watch in your computer, but the audience won't be able to see. You can just ask from your presentation.
Madam, if Madam can actually send the PowerPoint presentations, we can share from here. That is one option.
Yeah, that is
Another option is those speakers can share it from their own
their own PowerPoints.
systems.
They
Yeah.
have.
See, there is one by name Shraddha Agarwal is sharing.
Yes, madam, your screen sharing has started.
Shraddha Agarwal, you ask her to withdraw that.
Madam, we can see your screen. Now, please go to the PowerPoint presentation. Yes.
Yes, I am opening it. Trying to open.
It's opening.
Opening. Start. It's all. Opening. It's opening. So the, can you see now?
Yes, ma'am, we can see.
Yes. Put it in.
Go to
full screen.
Can you see now?
Yes, sir. Yes, sir. Thank you.
Very good evening to all. So the panelists are Dr. Lakshmi, the president, already introduced, President Calicut Menopause Society. Dr. Mumtaz, who is the secretary of Calicut Menopause Society. My own favorite student she was. She got the best paper award when we conducted a conference at Trichur. Dr. Santosh Kuriakos, again my student. Dr. Hira Prabhu, my friend's daughter, Professor KMC in KMCT Medical College. Dr. Fatima Tasneem, consultant and laparoscopic surgeon, District Cooperative Hospital. So now we'll start the presentations, the case reports. Many of the case reports are given by the panelists themselves. The first case is a 42-year-old lady, para-1 living one. Last childbirth was 13 years back with regular cycles. She presented with severe lower abdominal pain and vomiting of 1 day duration. On examination, she was pale, pulse rate was 110, tachycardia, BP was low, 90/60, SpO2 was normal. On examination of the abdomen was distended, diffuse tenderness and guarding, and free fluid was detected. Cervix normal, no vaginal bleeding. On vaginal examination, irregular firm mass fell through the left and posterior fornix. Exact size could not be made out due to the pain and tenderness. Uterus not separately palpable. Tenderness in all the fornices were there. So this is to the Dr. Lakshmi. Now, what is your impression on this case, Lakshmi?
Good evening, madam. Am I audible?
Yes, yes, very clear.
So here was a 42-year-old lady who presented with an acute abdomen, and because she was very pale on admission and she had all features of hemodynamic shock. And as evidenced by the examination, there seemed to be hemoperitoneum. The hemoperitoneum was the cause. There was no external bleeding. It was hemoperitoneum, probably, which was responsible for her shock. At the time of examination.
So,
okay.
And hemoglobin was only 5 grams. Urine pregnancy test was done, it was negative. And ultrasonography showed free fluid and enlarged uterus, probably due to multiple fibroids.
Yeah.
So,
this patient.
Yes, proceed.
So we did not have time for a detailed evaluation of this particular patient because she was already in a state of shock and her hemoglobin was very low. So an ultrasound was done in the labor room itself because we could not shift her to the radiology department to get a definitive opinion. And the whole lower abdomen, the patient was also in severe pain. The lower abdomen showed a very irregular mass and a lot of hazy echogenic areas as well, probably the blood clot, we don't know, but all we could make out was there was a mass in the lower abdomen and she had significant free fluid in the abdomen. So without wasting much time, we decided to go ahead with an emergency laparotomy. And at laparotomy, we were very surprised to find that she had a hemoperitoneum close to 1.5 to 2 liters. And she had a very irregularly enlarged uterus close to 24 weeks with multiple fibroids. And there was a very large sessile subserous fibroid, which was arising from the left posterolateral surface of the uterus with large surface veins, and one of which was bleeding. And at the time of opening, probably it was seen collapsed as well. There was also raw area at the base of the fibroid. So this was the picture at laparotomy.
So this is the commonest benign tumor, fibroid, subserous being the least common and least symptomatic. But acute abdomen in fibroid can be seen, could be a torsion, avulsion, red and sarcomatous degenerations also can occur very rarely. Spontaneous hemoperitoneum in a fibroid is rare, but can occur due to rupture of serosal vessel, as has happened in this case. Or less than 100 cases only have been reported so far. First reported case was by Carl von Rokitansky. Large or multiple fibroids exert a pressure on the uterus and hence an enlargement of the blood vessel, which may be further stretched and occasionally be torn. there can be precipitating factors. What are the precipitating factors, Dr. Lakshmi?
Yeah, mostly, see, the woman may be asymptomatic because most of these are large subserous fibroids, and a previous history of a pelvic mass may not be forthcoming as in this particular patient because she was totally asymptomatic, and retrospectively after the laparotomy on questioning, there was no history of menorrhagia and things like that. And except that she had not conceived for a long time. Her last, LCB was 13 years. But any factor which can give rise to an increase in the intra-abdominal pressure, say any violent act like a coital act or straining at stools or a violent cough or some trauma to the abdomen. And usually this happens premenstrually when there is a lot of pelvic congestion. So all these very seemingly simple activities can sometimes avulse a vessel and it can start bleeding, and it can precipitate a very life-threatening condition. And posterior fibroids are generally supposed to be at higher risk because they can directly rub with the sacropromontory and are easy to bleed. So trauma, torsion, and avulsion are the usual causes for acute abdomen in a fibroid uterus. And this is a very, very rare, though fibroids and subserous fibroids are very common conditions that we encounter in our day-to-day life. Bleeding from a surface vein on the fibroid is an extremely rare event. And whenever a woman who's asymptomatic with a large fibroid opts for a conservative line of management, one should warn her of this particular condition and timely surgery or treatment modality be adopted.
Okay. So a high index of suspicion in acute abdomen with a hypovolemic shock in the presence of abdominal pelvic masses, it has to be kept in mind. Large subserous fibroids, even in the young and asymptomatic, to be tackled before life-threatening complications occur. That is one point to be remembered. Case 2 is a 38-year-old lady, para 1 living 1. She had 1 MTP. She presented with abdominal pain. On examination, the uterus was enlarged to 20-week size. This happened in December 2012. Ultrasound showed a large leiomyoma 14 into 12 into 10 centimeters in the at the fundus with heteroechoic with irregular borders. And she had a myomectomy for that. The intraoperative findings, fundal fibroid, 20-week size, slight difficulty in enucleation. I was wondering why there was difficulty in enucleation of the fibroid. 2 units of packed red bloodlets were transfused. And the histopathology report came as leiomyoma. Everybody was happy. The doctor also was happy. In December 2030, that is 1 year, exactly 1 year after the previous surgery, she reported with pain abdomen, and on examination, uterus was enlarged to 12 to 14 week size. And we always suspect fibroid recurrence. Comment by Dr. Santosh.
Thank you, Sridhar Madam. It's a pleasure to be with you always. You are my beloved teacher. This is a real patient, actually. So when this patient came to us with uterine fibroid recurrence, we evaluated her further and we wanted to get the slides and blocks reviewed. So we took the blocks from the previous institution and the blocks were reviewed. Madam, can you go to the next slide? The block reported as and now we evaluated her thoroughly. She had a large heteroechoic mass, which is actually 20 centimeters in the fundus of uterus. And the CT scan also shows the same thing, but the point is it was a heteroechoic mass. It was not a hypoechoic mass that we usually see with well-defined borders. And as a part of routine examination, we did a chest X-ray and we found that there were 2 or 3 nodules in her left side of the lungs. So again, by the time we got the report, slide reviewed, the report was the original the tumor was actually not leiomyoma, it was a STUM, smooth muscle tumor of uncertain malignant potential. Okay. Now, so we diagnosed it as STUM with the uterine recurrence 1 year later. So So anyway, so she has only one child. So maybe that was the reason she opted for a myomectomy at that time. But this is what we found at the time of operation. So this, you can see at the fundus of the uterus, there's a large tumor, around 14-15 centimeter tumor, which is highly vascular, which is now showing surface itself shows vascularity and necrosis. And this was adherent to the surrounding structures. We dissected it from the surrounding structures, and the final HPR we got was leiomyosarcoma of the uterus. And patient was treated with chemotherapeutic agents. After this, even though we did a surgery, we removed the entire tumor en masse, but she had a recurrence. That lung disease actually progressed. Even though she was treated with doxorubicin, she died exactly 3 years later in 2012. By 2015, she expired. So the question is, can we actually diagnose, could we have diagnosed this tumor beforehand? So we should understand that all fibroids are not always fibroids, because 1 in 350 surgery for fibroid will have a sarcoma. And it's around 1% of gynecological cancers. And it is not that the old theory that it is arising from a pre-existing myoma is actually proved to be wrong. It is actually arising de novo. So, so now the question is, what could we have diagnosed it earlier is the question. And can you go to the next slide? Yes. There are few hints to this diagnosis. If there is a radiologist here, I think he will be very interested. Tawfiq will be interested in commenting. So, ultrasound with a myoma showing irregular borders or ill-defined borders, heterogeneous pattern. That is something we always take it as degenerated. But not all degeneration is due to degeneration. Not all heterogeneous is because of degeneration. But some heterogeneous pattern is because of leiomyosarcomas. And another thing is myoma will show calcification, whereas if it is a sarcoma, that classification is sometimes not seen. And color Doppler will definitely help us with showing increased vascularity. And one of the studies said that peak systolic velocity more than 40 centimeter per second is a good marker for detection. Now, another thing is you can go for higher imaging like CT scan or MRI scan. In all these things, what we are actually looking at is this heterogeneous areas, irregular borders, vascularity, and infiltration, if at all, to adjacent structures. So in diffusion weighted imaging in MRI is highest sensitivity and specificity, both estimated around 100%. So basically it is not possible, I know, to do all myomas before with evaluate with MRI, but those patients whom you can see an ultrasound showing these points that I have mentioned, such patients should definitely undergo an MRI, which will make your surgery as well as your procedure safe.
So the ultrasound also should be done very carefully so that you will not miss a necrosis or cystic lesions in the center and without a calcification. So that is very important point. So this is already, you have already mentioned this, no? You
Yes,
don't have to repeat it. Okay.
So this is the image, the right hand side, you can see the CT scan image that another patient we operated. So this patient actually came to us with a fibroid uterus. We found that she had a broad ligament fibroid, but unlike the usual fibroids, it was a little difficult to enucleate. But again, we went for a complete surgery in this patient. That patient was operated, I think, in 2019, and she came to me last month or last week, actually. So that was showing heterogeneous pattern. So that's a typical heterogeneous pattern. So to discuss such tumors doesn't have any not menopausal. Many people say it is a menopausal. Textbooks say it is menopausal women who come with glioma. No, absolutely wrong. We had our own case series. It is around 45-50 age group women who come with this. So they basically come with typical symptoms of fibroids. There is nothing like the rapid growth it's not found to be not a good indicator. And physical examination, there is nothing except that the nothing but high index. Madam has already said that word, high index of suspicion. keep a high index. Not all fibroids are fibroids, so malignant. So this patient actually went for a court case, and that court case is still not settled. So, so sarcoma transformation, I think a word about stem. So around 32% of stem will recur actually, around 20% will recur, of which around 1/3 will be sarcoma and 2/3 will be stem itself. So whenever you have got you should have a good pathologist. Another thing is your pathologist is your savior. If the pathologist tells you that this is a fibroid, you'll take it as fibroid. So if you had this pathologist given the report as stem, the things would have been much easier for the gynecologist.
Okay, thank you. So coming to the third case, another case, 61-year-old lady who was nulliparous, postmenopausal. She was diabetic, hypertensive on medication since 5 years, and on case of fibroid uterus since last 10 years. Referred in view of bleeding PV since 15 days, and she needed to change 2 to 3 pads per day only. And she also was having lower abdominal pain. And history of loss of appetite and early satiety was there. Heaviness in the abdomen since the last few years. On examination, pallor was present, PMI was 20.7, systems were normal. On abdominal examination, I think this is Dr. Mumtaz's case. Mumtaz?
Yes, ma'am.
Yes. Okay, you can start.
So the patient was in so much of pain, and the uterus was irregularly enlarged about 20 to 24 weeks of size, and there was tenderness. And pelvic examination again showed the same size of the uterus. And the ultrasound, madam, next slide please. Ultrasound had actually shown some amount of degeneration. The mass was also cystic to feel. Per abdomen also we could feel some areas were soft and cystic, unlike the feel of the usual fibroid. And even the pre-op diagnosis was whether it was a case of degeneration or sarcomatous change. And in ultrasound scan also, they had written the suspicion of sarcomatous changes or degeneration in the ultrasound. And the endometrium was thickened, it was 9 millimeter, and MRI was advised. So in the CT scan, again, there was a large mass. It was cystic in areas, solid and cystic in areas. And few foci of calcifications were noted in the periphery. And it was actually abutting the sigmoid colon and urinary bladder. Actually, when we opened, it was deep into the one part was deep, though it was 24 week size, one part was deep into the pelvis and also in between the broad ligament. So the pre-op diagnosis was uterine Curie suspicion of leiomyosarcoma was there. In addition to that, there was a thick endometrium. She is a 61-year-old postmenopausal lady, and we planned to do an endometrial biopsy, but she had severe pain, and it was like almost like a acute abdomen she was presenting, and she was a thin-built lady, and she was going into dehydration and all that. So we couldn't obviously wait for an endometrial biopsy report for another 1 week. So we proceeded with surgery. And again, there was cystic consistency, and it was very friable. And as we tried to take it out, there was a rupture of the things covering, and there was some amount of spillage also. And one part was impacted over the sigmoid, near the sigmoid, in between the leaves of the broad ligament. And there was additions between the bowel and the omentum. So this is the perioperative picture. This is the, actually when we saw this, this was like, it was like pus. It was yellowish in color, and there was so much of discharge. We thought there's maybe some infection due to secondary infection due to degeneration, because she was having so much pain also. And this is yellow slough-like material inside, purulent material. And previous slide, ma'am. Please, previous slide. And this whole thing was actually delivered out from the leaves of the broad ligament. One part is still inside. Yes, ma'am. Next slide. And we looked for the lymph nodes and we couldn't find any lymph node. And left ovary was not actually completely visualized. And there was also necrotic tissue, as I already mentioned. Though we sent it for culture, nothing came from the purulent material. Then the histopathology, the gross finding was like this. This is a specimen they cut open from the pathology department. And this is the histopathology. And the result came as we were expecting leiomyosarcoma, and they said it is carcinosarcoma. Madam, can you show the previous slide, please? And these are the elements of sarcoma, and these are the elements of carcinomatous area. So majority of the tumor had sarcomatous components. There was extension to both tubes and ovaries, but there was no lymphovascular invasion and luckily cervix was free. That means there was not much of extension beyond the myometrium, though the myometrium was almost fully involved. So immunohistochemistry also was more in suggestive of carcinosarcoma. So now this patient is, this was a recent case, just that we got the histopathology report last week. Now she is sent to the oncology department where they are planning chemotherapy for her. So this patient is a nulliparous lady, actually their poor socioeconomic status. She used to have vague abdominal discomfort, and 2 years ago she had a scan done and she was told that there is a mass and there is nothing to worry about it. And we couldn't get she doesn't have the scan report. So we couldn't see whether there was a rapid increase in size from that previous ultrasound. So anyway, she gives history of some mass being told to her. Maybe those people would have thought that she's postmenopausal and it wouldn't cause any harm. Maybe that's why it was left alone and she didn't have any complaint till 2 weeks back when she suddenly came up with sudden severe bleeding PV and severe lower abdominal pain.
But then the thing is, any postmenopausal lady with an enlarged uterus, always we have to rule out malignancy or whatever the pathology is, you have to find out and then only we should dispose the patient. No? So that has to be done. So a very, very interesting case. So coming to the fourth case, she's a 54-year-old lady, multiparous lady, postmenopausal, menopause 9 years back, presented with right-sided lower abdominal pain and history of urinary retention. There is no history of any bleeding, any discharge, dysuria, or abdominal distension. She was hypertensive and diabetic on medication. On examination, vitals were stable. Abdominal examination, there was a firm and non-tender mass of 14 to 16 week size. No other abnormalities on genital examination. The pelvic ultrasound, this, I think, Dr. Hira.
Yes, ma'am. Thank you so much, Sridevi, madam, and all the eminent gynecologists. So this case was a routine case of hysterectomy. We didn't find anything different, but during an it was a 16-week size mass which had come with abdominal pain and urinary retention. And on ultrasound, it had there was a large fundal fibroid-like mass, and it had a hypoechogenic rim which represented a layer of myometrium. They had given the diagnosis of lipoleiomyoma on ultrasound itself, and then they were not sure, and they asked us to get an MRI. It didn't cost anything to the patient. It was taken as an academic purpose, and it came as it was confirmed the finding of lipoleiomyoma, and MRI findings were MRI is the best modality to diagnose lipoleiomyoma, which is comparatively very much benign. And the reasons why MRI is opted is because of its multiplanar. We can take section in different planes, and it is highly sensitive, and it is very specific to fat tissue, fat identification. The ultrasound, which had a hypoechogenic rim, and it was just like a fibroid which had a hypoechoic rim of myometrium. Next slide, ma'am. MRI, it is definitely they are telling because of the fat, identification of fat and chemical shift. There is something called as a chemical shift in which you can identify the fat tissue more clearly, and it can rule out. We can also rule out like leiomyosarcoma with this MRI. So total abdominal hysterectomy was done routinely, and the section came out as microscopically came out as lipoleiomyoma, with abundance of smooth muscle cells and mature adipocytes. And she had a uneventful recovery. Yes, the gross, it completely looked as a clear, it's a yellow colored appearing mass on cut section gross, and histopathology showed fat cells enumerated along with smooth muscle bundles. So coming to the interesting thing, that it is around 10,000 cases have been reported, total 10,000 cases, and it is much more diagnosed these days because of these MRI and all these investigations available. And IHC has also been done, and it is positive for vimentin, desmin, and S100 protein. And it is interesting to know that it is associated with metabolic problems like dyslipidemia and hypertension and diabetes. And what they say etiology is the fatty metamorphogenesis. There is change in the smooth muscle cells in the myometrium to adipocytes, as well as, and there is conversion because of the immunology. And it has been, there are recent articles telling about the receptors and the genes which are involved in this. And the common presentations are very rarely it presents as AUB, and mostly it comes with pelvic thrust or pelvic discomfort. And it has been located, it has been explained, it has been seen in pelvis, extra pelvic sites also. And it should be differentiated from leiomyosarcoma by the leiomyosarcoma will have a bland appearance of nuclei, and there will be occasional mitosis in the smooth muscle component. And should we, one more thing is that in postmenopausal women, the rate of growth is much larger for lipoleiomyoma. We may think that sarcomas only grow, but these tumors are also known for the rapid growth when compared to the normal leiomyomas. And so we have to keep monitoring them if we are not doing, if we are keeping them for a conservative treatment. That's all.
The fibroids, leiomyoma will not progress in size after menopause because of the hormone.
There are few case reports also available in literature.
Okay, thank you. The last case. It's a postmenopausal lady, 56 years, para 2 living 2, currently asymptomatic, came for follow-up of fibroid, which was detected in 2019 in the perimenopausal period, the pre-COVID era. History of abdominal uterine bleeding for 2 to 3 years, fibroid of 3 centimeter size in the last scan, endometrial thickness was 15 millimeters, and endometrial study showed a proliferative endometrium, which was done. The study was done in 2019. LMP was in March 2020 at 54 years. That was the last period. So, Dr. Tasneem? Dr. Tasneem? Yes?
Yes, madam.
Yeah, present.
Good evening, respected teachers and senior madams. And thank you, Mumtaz ma'am, my own beloved teacher, for giving me this opportunity. So my patient is 56 years old, para 2 living 2. She knew that she is having a fibroid in her uterus, which was detected some 2 years, more than 2 years back, when she had heavy menstrual bleeding, which was treated conservatively as a perimenopausal bleeding. And then the fibroid size was 3 centimeters, but she was 54, almost 52 plus at that time. And she was counseled during that period that she's having a fibroid and she has not attained menopause. She has to be on follow-up. Due to COVID and all these things, she was not having follow-up after that, and she attained menopause at 54 years of age. After the COVID restrictions were lifted, she by herself went to get a scan done as a follow-up, and the scan showed an increase in size of, madam, next slide, please. So the scan that she did now showed a bulky uterus with posterior wall intramural fibroid with a submucous extension. And the size of the fibroid has increased compared to the previous scan from 3 centimeters to 5 centimeters. And the endometrial thickness was noted as 6 millimeters in the current scan with minimal fluid in the endometrial cavity and an associated hydrosalpinx on both sides. So she came with this report. And I did a pap smear, which came as negative, and per speculum cervix was normal. Uterus was bulky on per vaginal examination. And I counsel her because her uterus is increasing in size, even though she's asymptomatic, and uterus is bulky still after almost 2 years of attaining menopause. I counseled her for hysterectomy, and I took up her for total laparoscopic hysterectomy and bilateral salpingo-oophorectomy. Madam, previous slide, that was the picture of the intraoperative picture showing the fibroid, and result came as stage 1A grade 2 endometrioid adenocarcinoma of the endometrium and leiomyoma of the uterus. So from this case that I would like to highlight is, even though the endometrial thickness was 6 millimeter, I should have done an endometrial biopsy. Luckily, it is stage 1A without any myometrial involvement. Even then, that 6 millimeter with the uterus which has not reduced in size and fibroid still growing, I should have done an endometrial biopsy, so I could have avoided this alarming report. And also another possibility is because the posterior wall fibroid, they took it as endometrial fibroid with the submucous component. That there might have been a slight error in the calculation of the endometrial thickness, because that submucous component might be mistaken as the low endometrial thickness and increased fibroid size. Because along with that, sometime associated with this case, another case also I had where endometrial thickness was mistakenly recorded as low and the fibroid was registered as increasing in size, but that fibroid was heterogeneous, as Santosh sir was pointing out, and we did an MRI and we did an endometrial sampling, and which came as adenocarcinoma, endometrioid adenocarcinoma, and that was typical. But this one, no pre-operative hint were given whether it can be, there is any possibility. Only thing that she had a long menstrual duration, early menarche and very late menopause, and she developed diabetes. Apart from that, no risk factors were there. So this case was selected because I wanted to highlight, even though the endometrial thickness appeared to be just slightly increased or even normal, always go for a endometrial sampling in a postmenopausal woman with a fibroid uterus not shrinking in size.
Especially with this high risk factors, diabetes and hypertension also. Is there any, was there any family history?
No, madam, there was no family history. No, family.
No.
No history of malignancy in the family.
So the endometrial adenocarcinoma, grade 2 tumors show 5 to 50% solid growth. Carries 8.
She underwent the vaginal brachytherapy.
Okay.
Because it was grade 2.
Okay. And carries a 5-year survival rate of 88%. Small subset may display less than 5% solid growth, but marked nuclear atypia. They are also designated as grade 2. Is it Santosh?
Yes, madam. I think it's a well highlighted. I think Dr. Tasnim has well highlighted that there was actually, we should have gone for a sampling. That basically we don't want a surprise. That's all. I think that is well highlighted. Even Dr. Mumtaz also highlighted that she couldn't get the time for that sampling, so that it's very basics. We just keep headering. Again, patients again can come back and tell us why you didn't tell us. So basically, another point is the danger is that not knowing that there is a cancer inside, the surgeon may actually go in for a morcellation or cutting of the specimen, which can have disastrous consequences. So
that's also a lesson because I would like to highlight, for most of the postmenopausal women undergoing lap surgery for non-malignant diagnosis, never use the myoma screw to hold the uterus. Always hold on to the cornua, to the round ligament to manipulate the uterus. So that was one point I always stick on to while doing lap surgery. And the uterus was taken out through the vagina by manually just lateral coring. So luckily all those points were in favor for this patient. Just because of the grade 2, she underwent vaginal brachytherapy.
In this case also, we are actually not using myoma screw, using the long straight forceps to hold the two corner to lift the uterus up. But because it is open, it just broke. That is what has happened.
Yeah. That happens. But again, the point is, when you have a suspicion of a sarcoma, you should always document that this has been discussed with the patient. because patient will insist on myomectomy sometimes, and the doctor should always make it, because any capsule rupture, be it myomectomy, be it morcellation, be it cutting, anything you do with the capsule, that can have consequences which can be disastrous. But if you do a simple hysterectomy in an open method, that is going to save that patient. So there is a trade-off between this minimally invasive surgery and a safe surgery that will give a good life to the patient. So basically, you have to be careful. That's the message, I think.
And in any case of such menopause, perimenopausal or postmenopausal ladies, better that you go for epithelial aspiration at least when they are coming to the OPD. We can do that, no? So that any endometrial malignancy can be ruled out.
Also regarding that scan, madam, it would be prudent to just see by ourselves or have a second scan if necessary, if there is any doubt regarding endometrial thickness.
That is also, that has to be highlighted. A careful ultrasonography, meticulous inspection of the organs is mandatory, so that you will not miss anything. Okay, anything more you want to add? Yes,
that's it, madam.
Okay, so thank you all for the patient hearing, all the audience, thanking the organizers for giving the opportunity. President Dr. Shobana Mohandas, Dr. Lakshmi, President of Calicut Society, panel members, Dr. Lakshmi, Dr. Santosh, Dr. Mumtaz, Dr. Hira, and Dr. Fatima Tasmin. Thank you for
madam.
the cooperation.
Thank you, madam. Thank you.
Thank you so much, madam.
Thank you very much, madam.
Okay.
Thank you, madam.
Thank you for giving the opportunity, Lakshmi.
There were so many good cases, and there were so many national people from all over India have logged in, and I'm very sure they got a very good feast from such great number of cases that Calicut has given.
Very important, very
lovely cases from everybody.
Cases are very nice. You get everything in Calicut. Any type of.
So welcome to Calicut for IMSCON. You can see the taste of Calicut from here.
Yeah, coming for that.
Sarla Jain was saying, when can we give the brochure? You know, she was asking.
Very soon,
So
very soon. I'm working hard.
They're all
on it.
ready to come to Calicut.
She's working hard.
I'm working very hard on it.
Yeah,
Just
Anju
few
Gupta,
days.
Sarla Jain, everybody please come.
Definitely,
to
definitely.
Calicut. We will give you a good academic feast, no? Lakshmi?
Yes, very much.
Yeah. Can you stop sharing, madam? We can see each other.
Okay, stop share.
Yeah, anybody else wants to discuss about this? Anybody from outside Calicut or inside Calicut? Anybody? I think we are running late also, but we had a lovely time. We clearly it has given a half an hour little extra also. No, we are on time.
We are on time, madam.
On time.
We are on time. We are pretty much on time.
8-4.
But lovely, I think we had a good discussion.
Lalitambika, madam, do you have any special comments on anything?
No, it was actually the panel discussion was very wonderful. So many very rare cases which you may get only in Calicut.
Any type of cases you will get.
And Lakshmi has taken hard work to correctly people she has got who will have good cases.
The credit is also to the panelists. They have given me the best case.
That was a very good information. Endometrial thickness 6 millimeter because it may be due to compression of the fibroid. Maybe it was a thicker endometrium which was missed. And definitely
probably thicker.
It was
Yes, madam, because I had a case concurrently, another case, but in that the fibroid had a heterogeneous appearance. So it was like query fibroid, query mass. So we did an MRI and MRI was suspicious of malignancy and got an endometrial sampling which showed a adenocarcinoma of the endometrium. So that case was there, and this was both these cases keep.
Sometimes you won't even get endometrium with such a small thin thing. You put your people in, go up and down, up and down, up and down. You won't even get anything. That is also there in some cases.
Yes, but we are saying medical legally. We attempted, we didn't get. Even if
Yeah.
the report comes as C endometrium,
Yeah,
we
of
are
course,
safe.
that is there. I'm just telling you all spectrums come.
Madam, endometrium sampling, what you can do is you can use the PPLA with the syringe attached to the.
Yeah, we always do that only.
So that, to our experience, it is very good. We have actually now stopped doing
That
this.
syringe one is always necessary.
So I think there is two types of PPLA. The initial type was the plunger inside. So
No, that doesn't
doesn't
work.
create adequate negative pressure.
No.
You can always put a syringe, 10 cc syringe, and that will, I think, it is 99.7% sensitive, as it is rightly said. Another question I wanted to ask was, in 2018, the FDA has actually made a huge underlining and red for the uterine morcellators. So basically, where do we stand? Because I don't practice that thing. So basically, where do we stand with it? Because of the same.
Actually, the foreign countries have banned the morcellators, but we are having in-back morcellations, and so why should we not do it? And this endometrium, you are saying that endoscopy should not be done for postmenopausal. That's taking things too far. I think what you can almost say that please do an endometrial biopsy before you do all this work. But even otherwise, we do give a good wash after the surgery is over. So, but just one drop of endometrium falling in the abdomen, whether that can cause, cancer is doubtful, because even in patients with grade stage C ovarian cancer, what they say stage C is when the capsule has ruptured and inadvertent rupture of the cyst while doing endoscopy. These two are also ruptures. But the point what they have said that inadvertent rupture does not increase the staging and the prognosis has never been affected. Whereas, actual rupture by growth of the tumor and then it ruptures. There actually the grade is higher. That's why it has ruptured, not puncturing it. So it's the grade of the tumor, not just the inadvertent putting of the tumor cells onto the abdomen that is going to really improve. Of course, there are port site metastasis has been described. So probably endometrium dropping into the abdomen also might cause, but how many cases we all see that we can give statistics? So may it's just one off to get scared and stop all laparoscopies after postmenopause. That is calling it too much, I think. Yes.
I just have one case which I would like to take an opinion from you. She's a 25-year-old unmarried girl with a fibroid of close to 26 to 28 weeks. And the ultrasound says that it is a large anterior wall fibroid. The uterus is extremely deviated to one side on the right, towards the right. And she has an endometrium of close to 20 millimeter on day 7 of menstruation.
Oh. No, that could be because of the high estrogen content coming from the fibroid itself. I wouldn't say it is endometrial cancer. Of course, you can diagnose. But I think you can as a pipellet or whatever it is. I mean, just don't worry about her hymen rupturing. But I think it's worth it, no?
How about the ovaries, madam? Ovaries
appear normal.
We should undergo a myomectomy with that.
Yeah, we got an MRI done as well, but it doesn't say anything about any untoward vascularity or anything. But very surprised to see that the endometrium was so thick and echogenic.
So such a big tumor, why should the endometrium not be thick?
Has she taken some uliprostol from somewhere else?
No, she has not taken anything, nothing at all. She's not had any sort of treatment. She's awaiting
Ayurvedic medications.
She's awaiting a myomectomy. She's not had any sort of treatment.
Unani.
I was surprised to see the 20 millimeter thick endometrium.
Any abnormal bleeding? Any abnormal?
No, she's not symptomatic.
No, and I don't know if it's so much of estrogen is there. There could be a polyp also. Doesn't matter.
Yes, my endometrium polyp can be there.
But the problem was very difficult to sample it because she's unmarried.
No, that we'll have to forget this married. Let her marry a guy.
I'm sure the people will not reach anywhere there also because it's
no, you remove the myoma and after that you sample it and let her marry a sensible guy who will accept her with all her this thing. That's all.
Sampling is going to be difficult.
Minus the hymen, if somebody can accept her, you should marry only such a person.
It's not just that, madam. The pipple is not going to reach anywhere near the cavity because it's so high.
No, after the fibroid is removed, then it will.
Madam, hysteroscopy can be done. A thinner hysteroscope can be done even without rupturing or damaging the hymen much.
Yeah.
I think we have to get out of this hymen mode now. We are in the 20th century and this hymen talk is getting too much now.
Yes, definitely. But even if anybody is having concern, the hysteroscopy can be done.
Yeah, that's true. That's a very good option. Jyoti Jaiswal is from Raipur. She is the Joint Secretary of IMS. She's also working in a medical college. But Jyoti, do you have a office hysteroscope in your medical college?
Not office hysteroscope, madam, but yes, we have office hysteroscope, but not using in office, actually using in OT only.
Yeah, that
We have
everybody does. But
hysteroscope.
you have an office hysteroscope in Raipur
Yes,
Medical
yes,
College.
Yes, we have.
That's good. This is one reason why you should be buying an office hysteroscope at Calicut Medical
No,
College.
we do have, madam. We do have a hysteroscope.
Yeah, so you can use it. Yeah, simple.
Okay, then Mumtaz, if there are no more questions, I think we can wind up.
Yes, ma'am.
Dr. Lakshmi, it was really a very lovely program. Congratulations to Sobhna madam, Lakshmi madam, and all the senior people who have given us insight about these rare complication and rare cases. The routine cases we always used to listen, but the rare things should, yes, it is a very good step. Thanks for that.
Thank you.
Thank you for attending all people.
It was a team effort.
Thank you, Dr. Jyoti. Shall we wind up, madam?
Yeah.
So, so we have come to the end of another webinar session, and we have really kept the time also. We started at 6 and it is only 8:10. So as a Secretary of Calicut Menopause Society, I take this opportunity to thank each and every delegate, first of all, who had logged in to make this a grand success. And I also thank Dr. Suvarna, our chief guest, Dr. Jignesh sir and Dr. Anshu Soni ma'am for being the guest of honor and talking to us, and Dr. Shobna Mohandas, who is founder of our Calicut Society, for that wonderful talk, Dr. Shobna madam, and Dr. Taufik for that very informative talk on intervention in uterine artery embolization. I also thank the chairpersons, Dr. Beena Guhan and Dr. Chandramadi, Dr. Lilidambiga and Dr. Jeena Bagraj. And I express my sincere thanks to Dr. Sridev madam for conducting that beautiful panel, for making all panelists very comfortable. And I also thank the co-panelists, Lakshmi madam, Dr. Santosh, Dr. Hira, Dr. Tasneem, and Dr. Tasneem. I also thank the ClearNet team for having sponsoring us for this program, for airing this program. So once again, I thank each and every delegate who have joined us all across India. I should say that people from many states. Always IMS is uniting the states of India in one platform. Very happy to see that. So till we meet again, I think it's a thanks and a good night.
Good night.
And welcome to IMSCON 2023.
Yeah, welcome. Thank you.
To be associated with Calicut, always.
Okay.
Oh, thank now you are in Alapura.
Yeah. Okay.
Thank you so
Thank
much.
you
all.
very much.
Thank you, Shobana, for arranging such a good, and Dr. Lakshmi for arranging such a good.
Thank you, madam, for joining us. Thank you.
Thank you, everybody who's coming.
It was our privilege to have you, Sridevi madam, and all that after such a long time. We are very much looking forward to it. Thank you very much, all of you, each and every one of you. And good night, all.
Thank you, Shobana madam.
Thank you, madam. Thank you for coming.
My students. Okay.
Nice meeting each other on the web platform. No?
Very much, very much.
Okay, then bye. Good
Bye,
night.
ma'am.
Have a
Thank you.
great
Good night,
week ahead.
everyone. Good night.
Night.
Good night, all. We are closing here.
Yeah.
Thank you.